Good evening, ladies and gentlemen. Welcome to this session about antithrombotic dilemma and strategies. I am Marie-Claude Morice from Paris, France, and I'm very honored to co-chair this session with Dr. Michael Gibson. We have a nice group of expert panelists: Dominick Angiolillo, Shinya Goto, Upendra Kaul, Byeong-Keuk, and Duk-Woo. Welcome to all of you, and thank you for being with us. Mike, I'll let you introduce the first speaker.
Great. Well, thanks, Marie-Claude. And our first speaker is going to be Dr. David Cohen. He's going to talk about NACE, or Net Adverse Clinical Events, with antiplatelet therapy and ACS and PCI. Are we really balancing bleeding and ischemic risk, or are we just simply reducing sample size? So, Dave?
Well, thank you very much, Mike and Marie-Claude and all the organizers for inviting me here to start off this session. So I've been tasked really covering some of the methodologic challenges about composite outcomes, in particular focusing on the idea of net adverse events in PCI and ACS trials. These are my relevant disclosures. So composite endpoints are very common in cardiovascular trials. In fact, most contemporary trials use these composite endpoints. If we look at trials of lipid-lowering therapies, we see cardiovascular death, MI, and stroke. Heart failure trials very commonly these days look at a death or heart failure hospitalization. And drug-eluting stent trials often use target lesion failure, which is a composite. And the rationale here is largely to both improve statistical power and to reduce the sample size, but also to avoid some of the analytic challenges related to competing risks of mortality, as well as multiple comparisons. However, composite endpoints also have a number of important drawbacks that we need to recognize. In particular, the interpretation can be challenging or even misleading if the endpoint components have a differential impact, as they often do, and if the endpoint is driven by the less severe components. And this is partly because the usual way we analyze and interpret these composite endpoints implies that they all carry the same clinical weight. Although we can use alternative weighting schemes, they're difficult to implement and really have rarely been done. And then, as I'll show you, we have even greater challenges if the endpoint components move in different directions, which is often the case in the antiplatelet and antithrombotic arena. So let's just look at a couple of prototypical trials and the different scenarios that come up. So here's a trial, the Epistem Trial, done about 20 years ago. And this is really the best case for composite endpoints. You can see the results in the two different groups, the stent plus subsiximab group versus the stent plus placebo group on the left-hand side. And what you can see here is sort of the ideal circumstance where all of the different endpoints, including the overall composite, go in the same direction in favor of the absiximab group and to a relatively similar magnitude. This is a very easy result for us to analyze and interpret. However, this example that I'm showing next, this is the Gamma-1 trial that Ron Waxman ran of gamma brachytherapy. And this is the usual scenario that we run into. So here again, the brachytherapy had a major advantage over placebo for reducing the primary endpoint of cardiac death, Q-wave MI, or target vessel revascularization. And in the conclusion of the paper in the New England Journal of Medicine, the authors said this study showed that in patients with vein graft in-stent restenosis, brachytherapy reduced the composite of cardiovascular death, Q-wave MI, or target vessel revascularization by 73%. Sounds very impressive. But let's look at the actual data here. The data showed no difference on cardiac death, essentially no difference on Q-wave MI, and this enormous difference on target vessel revascularization. So even though all three components are represented, really only one is driving the benefit. And this is really the more typical, and it's usually, as in this circumstance, the least important of the three composite endpoints. But the most challenging scenario for us is this one. So this is the scenario where we have conflicting endpoints. And the example I'm showing you here is the primary analysis of the Syntax trial. This is the one-year results of the trial comparing a multi-vessel PCI with the Taxus stent versus bypass surgery. You can see that in the composite endpoint on the left-hand side here, there was a substantial benefit of bypass surgery compared to drug-eluting stents. But again, if we look at the endpoint components, what we see for the four components here, death and MI were relatively similar, trending to favor CABG a little bit. Revascularization was strongly in favor of bypass surgery, and stroke was the opposite. And so now here we have an endpoint where the composite favors bypass surgery, but what we really see, what's happening at least at the 1-year time point, is a trade-off between stroke and revascularization. And obviously those two endpoints are not nearly of the same magnitude. And so now we're struck with a dilemma of how do we actually interpret this. So what does this all have to do with antiplatelet and antithrombotic therapy and PCI? Well, what it has to do with it is because in PCI and ACS, we often have this trade-off. So here are 4 representative trials over the last couple of decades in the PCI and ACS space. Replace 2, bivalirudin versus heparin 2B3 inhibitor, the Triton-TIMI-38 trial, prasugrel versus clopidogrel and ACS PCI, the DAP trial, long versus short DAP, the Compass trial, low-dose rivaroxaban. And what you can see in each of those trials, the ischemic events go in one direction and the bleeding events go in the other direction. So we have a very clear trade-off in all of these trials. How do we reconcile this? How do we interpret these results? How do we, conduct these trials? And one of the proposed solutions that has been increasingly frequent over the last several years is the idea of looking at net adverse events, where we sum up both the ischemic and the bleeding events. And so I want to just take you through kind of 3 different scenarios and 3 different approaches that can be used to balance the safety and efficacy endpoints. So one is the one I've just been speaking about, net adverse events, where we're taking a composite of death, MI, stroke, and bleeding. And the strength of this approach is fairly evident. It incorporates the full spectrum of adverse outcomes, both the ischemic side and the bleeding side. It's relatively patient-centered. But there's a lot of clear disadvantages or challenges. First of all, it's weighting all the endpoints the same, and death and bleeding are not necessarily on the same order of magnitude. Very importantly, we have to remember that the idea that net adverse events can improve your power or reduce your sample size only works if the therapy has directionally consistent effects on all the endpoints. If the endpoints go in different directions, you really don't get an improvement in power. In fact, you may get less power. And finally, it's very challenging to use this approach in a non-inferiority design, which a lot of our trials tend to do, because if you're putting all of the endpoints into one basket, into one composite, why would we accept the possibility of net harm, which is implied by a non-inferiority trial? So what other approaches are there for balancing these effects? Well, another approach that is starting to get used increasingly is the idea of an ordinal composite endpoint, where we take all of the endpoint components and we order them. We say which one is the most severe, which is the next most severe, which is the least most severe. The strength of this approach, again, like net adverse events, is it does incorporate the full spectrum of outcomes, and it allows for the more impactful endpoints to take precedence. So death would be far more, weighted far more strongly than myocardial infarction. But even the ordinal composite, which is again a major advance, has challenges. In particular, again, the interpretation can be challenging from a clinical standpoint if the components move in different directions. But I think the most important thing to keep in mind about these ordinal composites is they're only really informative for the average patient, and they can't easily adapt to different risk profiles. So if you have a trial where we have bleeding and ischemia all in there together, we get one average effect. But if we want to apply it to a patient who's particularly high risk for bleeding, we can't easily do that with the ordinal composite component. And similarly, if we want to look at a patient who's very, very high risk for ischemic events. So it does still have these challenges, even though it allows for more nuance. The final approach, which again is getting some traction and beginning to be used a little bit more, is to retain the separate endpoints for efficacy and safety, and then combine them in a post hoc analysis to look at net adverse events. And so here I think we start to get kind of the best of both worlds. We still can incorporate the full spectrum of adverse outcomes. We can combine things like non-inferiority for one component with superiority for the other, as was done in Dr. Meron's Twilight trial that I know she'll be describing a little bit later in the session. It allows for us to explicitly model the risk-benefit trade-offs for specific patient profiles. In other words, trying to really achieve our goal of personalized medicine. The limitation here, of course, is that it doesn't take advantage of improved power if both of the different endpoint components move in the same direction. So there is no free lunch. You always have to give up something if you're going to get some other benefit. But I wanted to spend the last couple of minutes on this idea of modeling the risk-benefit trade-off. So this is something we've been very interested in for quite a while. This is data from the Triton TIMI-38 trial with prasugrel versus clopidogrel, which, as you recall, in that trial, there was a very clear trade-off. There was a reduction in ischemic events, mostly MIs with prasugrel, but it was also accompanied by an excess of bleeding. And so what we did here in this example that was led by my colleague, Adam Salisbury, is we used primary data from the trial to develop separate risk prediction models for ischemic and bleeding outcomes. And then we applied that model to each individual in the trial to provide personalized assessments of risk versus benefit. And what it looked like is this graph actually shows the trade-off between the risk of ischemic complications on the x-axis and the risk of bleeding complications on the y-axis for every single patient in the trial. And this light blue line here actually shows the unity line if we assign equal impact to bleeding and myocardial infarction. And what we can do with this sort of separate series of models is we can say, well, where does let's say we have a 45-year-old man with diabetes, a non-STEMI, and radial access. Where does he live? He lives over here in this lower right-hand quadrant where he's getting a lot of ischemic benefit from prasugrel and only a small excess of bleeding. But what about this other patient, a 66-year-old woman with a STEMI with femoral access? She, on the other hand, only gets a very, very small amount of ischemic benefit, but has a much higher excess risk of bleeding. And so you can imagine the trade-off for these two individuals would be very different when we model this heterogeneity of treatment benefit. Another example of the same, using a slightly different approach with a risk score, was Bobby Ye's the DAPT score for looking at long versus short DAPT. And again, by breaking out patients into quartiles of this DAPT score, he could really separate out the risk of stent thrombosis. The higher the DAPT score, the greater the benefit with respect to stent thrombosis and myocardial infarction. And the lower the DAPT score, the greater the risk of gusto moderate or severe bleeding. And when all these were combined in the net adverse events, you could see that the DAPT score really nicely segregates and separates that risk into a group of patients who are predicted to really get substantial benefit from prolonged DAPT, and a group of patients who are either going to be very neutral or likely harmed by the prolonged DAPT. So again, keeping the net adverse events separate really allows us to look separately at these different components and to model that heterogeneity, which is very important for patient decision-making. So just to summarize, and then to set the rest of the session off, despite several evident limitations, I think composite endpoints for clinical trials are likely here to stay. We just don't test enough things that are really going to reduce mortality these days. I do think that the use of net adverse events addresses some, but not necessarily all of the concerns around composite endpoints. It does not generally address our concerns about equal event rating and the different severity of different events. We have to keep in mind that it really only improves study power if the treatment has directionally consistent effects on both safety and efficacy. And the main value of the net adverse event framework is, again, providing this framework for balancing patients' benefits and harms, at least for the average patient. However, as I outlined kind of in my later examples, I do think that some of the novel approaches, including ordinal composite endpoints and modeling the heterogeneity of treatment benefit, are likely to assume increasing importance for both regulatory and clinical decision-making in the future. Thank you very much.
Thank you. Really excellent opening of this session. Things are put in perspective thanks to this lecture. Next one is from George Dangas. We move to the TAVI patient. Antithrombotic for TAVR patient, trees, and the forest. George, please.
Thank you very much, Marie-Claude, for the introduction, and many thanks to the organizers of TCT Asia Pacific 2021. I'm very pleased from snowy New York to join and present to you the status of 2020 and 2021, I should say, in TAVR antithrombotics. Many things are anticipated in this rather complex subject that includes a patient population with a lot of baseline atherosclerotic risk, primarily due to age, but also due to comorbidities, as well as impacted by periprocedural cardiovascular and bleeding events, as well as the new onset atrial fibrillation that occurs somewhat infrequently, but not too. Also, it is a real phenomenon postoperatively, perhaps as an undiagnosed phenomenon. The prosthetic valve thrombosis that everybody has been rather concerned over the years seems to be a multifactorial phenomenon related to surface factors, hemodynamic factors, and hemostatic factors, and their complex interplay in specific patients. This type of phenomenon has been long described in not such detailed organized studies in surgical bioprosthesis, and you can see that on the left side there is a thrombosed bioprosthetic valve, on the right side one with degeneration with pannus. You can see from the graph that perhaps the degeneration occurs at a little later time point. There is always a question whether the thrombus precedes the degeneration and somehow also in some ways causes it. This has always been a question and an unproven, yet unproven because it's unstudied theory. The advent of imaging brought this phenomenon very close to us, as indicated in many I should say, case reports of different leaflets, and everybody was so astonished how the new technology, the four-dimensional CT angiogram, was actually able to create little movies of the valves as they move and identify very clearly immobile structures in the leaflets. Everybody was very concerned because of the theoretical possibilities of where these clots might travel. Turns out these haven't been traveling a whole lot towards the brain, which is a good thing. On the other hand, in more organized studies now with serial follow-up, something that was depicted here on this slide, as you see, with a balloon expandable valve, but at the same time, very similar exists for the self-expanding valve in both patients with the new valves as well as the prosthetic by the prosthetic valves with surgery, rather similar, but most important, one can see in this slide, the phenomenon is not a static one. Little thrombi in the valves come and go regardless of antithrombotic therapy. What you see in this slide is that patients who had it at 1 month may or may not have it at 1 year, and people who have it at 1 year might or might not have had it at 1 month. So that's a very puzzling phenomenon, is that it does occur to a sizable number, maybe about a quarter of patients by 1 year, but it's not really the same patients who have it all along. So that remains puzzling. On the other hand, we know from these studies that the comparison to surgery is rather similar at the 1 year horizon. So it is a real phenomenon in the end of the day that we need to try to figure it out in a more organized way. The guidelines have been mainly driven by expert consensus, as you see at the blue bars. The level of evidence is C, and in general, we are in a grade 2, level 2 of the guidelines for the most part. You can see a level 1 indication that states the obvious because it deals with patients with transcatheter bioprosthesis who have another indication for anticoagulation. That's essentially is not really a valve derived, is an indication derived by the comorbidity. Let's organize our discussion now in looking at 2 different populations so we all understand where we are. The first population I'm going to look at is a successful TAVR with no underlying oral anticoagulation indication. And first, I want to present in one slide our earlier, not so far behind though, a retrospective study of the Bravo 3 trial indicated that those who received the clopidogrel loading versus those who did not actually had no advantage, and the only thing that was higher vascular complications for those who received the clopidogrel loading. And pretty much this type of excess of vascular or early bleeding complications was seen in several smallish studies who compared aspirin to clopidogrel. In each and every one of them, clopidogrel was not given post-TAVR only, it was given pre-TAVR with a loading dose for the most part. And you can see there was a cluster of events in all the studies early on, primarily bleeding and vascular in nature. A little higher, still, I would say, in my view, a limited sample size of about 300 patients per group is this trial, the Poptavi cohort A, that again started clopidogrel before the procedure with a loading dose. And again, the flavor is the same, a lot of activity with bleeding early on, not much of events beyond the first few days though. So one can imagine, can actually incriminate for the most part the loading dose and the periprocedural vulnerable bleeding period to this disparity. As far as the ischemic outcomes, one can see some preponderance of the clopidogrel early on, no difference though. Interestingly, one can also see that for the first time, once the drug was discontinued, everybody was on the same situation with aspirin alone after the first several months, up to a year. You can see that the aspirin alone arm does have an upward drift of events, and one could consider this the first trial to perhaps describe this phenomenon, that the absence of early on intense antiplatelet or antithrombotic therapy of some sort may indicate a smaller updrift of events later in a later phase. In my view, is a question mark. It may be a play of chance to be determined in another trial. In Galileo, we took a different pathway utilizing an intermediate dose of the anticoagulant rivaroxaban, 10 milligram, in a similar patient population in combination with aspirin for 3 months and then on alone, in combination with DAP for 3 months and aspirin alone later on. This regimen, particularly in the longer term, did not seem to have a significant impact. In fact, there was harm primarily due to the mortality pretty much late after drug discontinuation and later in the phase of the study. And there was also a trend of bleeding with the rivaroxaban arm. So despite the low dose used, a lot of low dose used, about half really the normal atrial fibrillation stroke prevention dose, still was not really so successful from clinical point of view. What was successful, on the other hand, and that creates an interesting disparity, although it was a medium dose anticoagulation, it was very effective in reducing the leaflet motion and the microthrombi on the valve. And as you can see here, I depict the rather complex, however easy to understand if you see it, categorization we utilized in this study. And you can see here the dramatic reduction in both reduced leaflet motion or the leaflet thickening. And again, I underline even with a medium dose of the anticoagulant. So based on this study, one can say that if from a mechanistic point of view, you don't really need the full anticoagulation to impact those valve thrombi. On the patient population, though, you see that doesn't make much sense to do it indiscriminately because you're going to have side effects. We're looking forward in 2021, later in the year, to the outcomes of this study, the apixaban 5 BID stratum 2, where patients with no indication for anticoagulation, where I compare this experimental regimen of full dose anticoagulation, a different strategy here, compared to either dual or single antiplatelet therapy. And let's move on briefly to patients with who get a TAVR and do have an underlying oral anticoagulation indication. First of all, exploratory small retrospective study from Germany indicates that a non-vitamin K oral anticoagulant may actually have a favorable impact in the selected patients, as I see here. Let's see what's happening in the randomized phase. And we have only one study here, the cohort B of the Poptavi, again, a limited population, just about 150. Let me note that in this study, everyone was started pre-TAVR, or nearly everyone was started in pre-TAVR in those regimens and underwent TAVR on oral anticoagulant plus clopidogrel versus on oral anticoagulant alone. I think this is a practice that at that time, in the frenzy of stroke prevention, it was adopted by the investigators. Clearly, these days, I don't think anyone performs TAVR on oral anticoagulation uninterrupted. So that explains that in general, on the left side, you see quite a bit of bleeding, around between 10 and 20% in the control arm, and between 20 and 30% in the experimental arm, the combination arm. Nonetheless, there is a difference, but I want to point out that due to the specific design of the study, I think the event rates of the bleeding are quite a bit inflated because of this pre-procedure start of the medications. On the ischemic part, again, you can see that clopidogrel addition did not seem to offer much. Actually, they continue to be somewhat inferior to those results. In 2021, we look forward to the envisaged TAVR-AF. A total of 1427 have been enrolled. A follow-up has been completed. The database lock is anticipated for the spring, and results are anticipated in ESC 2021 in comparing patients with atrial fibrillation and TAVI, warfarin, INR 223 classic versus edoxaban 60 milligrams with a downgrade to 30 for renal insufficiency, and with specific clauses and stratifications whether the patient had a recent stent and needed a coronary stent and needed perhaps an antiplatelet in combination. 12-month follow-up, and let's see how this pans out. And also, we saw earlier the Atlantis cohort 1 that will indicate with the results with apixaban versus the warfarin. In general, my last slide that indicates that in the wake of all these rather small, rather limited studies, as far as the patient population and how definitive the results have been, they have not, you can see that there is a multi-division of the different practices and how different could it be, and you can see all these possibilities followed per hospital, usually per heart team decision with a lot of variability. So in conclusion, we see that everybody had been nervous regarding the lifted thrombosis post-TAVR. However, we've been relieved by the fact that it doesn't mean to have an immediate stroke or TIA risk, and we continue to investigate it regarding its limitations, perhaps implied regarding the valve durability. Clopidogrel loading can be incriminated to a lot of peri-procedure bleeding without obvious benefits, and I think this has been largely abandoned. The guidelines continue to indicate a limited 3-month dual antiplatelet regimen. I think at this point, everyone is starting that after a successful TAVR upon discharge or upon resumption of the home medications. The experimentation with a low-dose anticoagulation was successful at the valve level with a CTA, however, had clinical unfavorably results regarding the patient population level, and therefore will continue to be able to need to study it further in order to reconcile those. And finally, in patients with oral anticoagulation, understanding that we can reduce in general the bleeding complications by avoiding clopidogrel. At the same time, we should probably be careful and start the anticoagulation not before but after the TAVR. Finally, we continue to strive for more large-scale randomized evidence regarding how to properly treat these patients and inform the guidelines. Thank you for your attention.
Thank you. Very interesting, even if there is not yet conclusion, at least for the patients which are not on AFib. We will ask now to Dr. Lopes to make his presentation in PCI and AFib trials, less bleeding but neural ischemic event. Is it justified for all-comer PCI and AF patients? Dr. Lopes, please.
Okay, so let's in the next 10 minutes or so try to review where we are in terms of this AFib and PCI patient population. Here are my disclosures. So why this topic all of a sudden became so important? Because these patients are common in clinical practice. We all face them and have to treat them every day, if not every week, in our practice. And if we could summarize the problem, here is the summary. We need to use dual antiplatelet therapy to prevent stent thrombosis, myocardial infarction, recurrent ischemia. But on the other hand, because these patients have AFib, we also have to prevent strokes with oral anticoagulants. And the problem is that when we combine these therapies in what's so-called classic triple therapy, 3 drugs, the risk of bleeding goes exponentially high. And the bad news is that there is no way we can treat the 3 things at the same time. We cannot treat the myocardial infarction, the stent thrombosis, the stroke, and the bleeding. So if that's really not possible, what's our goal? Well, our goal is to find what I've been calling finding the sweet spots. And I think that's the challenging that we live in this situation. How can we find the sweet spot? In other words, how can we find the right combination of drugs at the right doses for the right durations that can give me the greatest reduction in ischemic events at a minimal cost of bleeding, which again is never going to be 0 because we are using here antithrombotic therapies. But if you can find that sweet spot, then I think we found the best to our patients. However, finding this sweet spot is not very easy. And here's a slide from Mike Gibson, who I always very smart in doing this slides and summarizing the problem. And I think here is really the summary of the dilemma of this session. There are 2.8 million combinations to treat these patients. And how can anyone or any guidelines contemplate 2.8 million combination of options? Really, really not possible. And that makes this clinical scenario so difficult. And until very few years ago, we had almost no high quality evidence to really guide the decisions. And basically, as I used to say, every guidelines or every perspective piece until that moment was more like a scientific fiction, honestly, because everybody was basically just recommending whatever they wanted. So the only way to close this gap is to really do the randomized trials. And of course, we cannot do 2.8 million trials to test every single combination. So we need to pick the ones that we think are more relevant and then do the appropriate randomized trials. And this is the progress that we have done in the last 4 or 5 years. Now we have 4 important DOAC trials in this field. We have one Warfarin trial, the Wolves trial, that actually was the first trial risking or testing the hypothesis of stopping aspirin for this patient population. And here is basically the design of the 4 trials. Of course, we need to be very careful when we interpret or when we analyze these trials. We don't have the time here to go in details in all these trials, but as you can appreciate, the trials were quite different because they tested different anticoagulants, they tested different doses of anticoagulants, they tested different strategies, they have some similar population with some differences among the trials, and they have different durations as well. Most trials look at patients or follow patients for 12 months, and Augusta's trial follow patients only for 6 months. So again, very important advance in the field with good randomized data, but with some differences that we need to take into account. But if we could summarize then all these trials together, if we could put this in a meta-analysis that we just published less than a year ago in JAMA Cardiology, what did we show when we combine all this data into a meta-analysis? Well, to perform this, we have to do a network meta-analysis with these 5 trials. And here it needs to be a network meta-analysis because we're not comparing drug A versus drug B. We are really comparing a strategy A versus a strategy B versus a strategy C versus a strategy D. And those strategies are the ones that were primarily tested in the randomized trials. So basically, triple therapy with warfarin, triple therapy with a DOAC, and then double therapy, no aspirin with warfarin, and double therapy, no aspirin with a DOAC. So these are the 4 regimens that were tested in these trials. And if we could summarize almost 12,000 patients worth of data, this is the summary. On the upper part of the graphics, if we look at bleeding, including intracranial hemorrhage, no question that a NOAC plus a P2Y12 inhibitor, in other words, no aspirin, is the better option. We have a clear gain on bleeding side if we drop aspirin. If we look at the bottom part of the slide, on the ischemic events, at least myocardial infarction, stent thrombosis, or even revascularization, we don't seem to pay a price or a high cost for dropping aspirin for most patients as a default. Obviously, we are now learning how to customize and how to refine the treatment about these patients as we go further from the PCI, but in general, for most patients, we don't have a cost to pay in terms of ischemic events. And that's, again, is the best data we have out there with 12,000 patients worth of data. So here's the summary of this meta-analysis, basically showing that the patients with AFib undergoing PCI, a NOAC plus a P2Y12 inhibitor without aspirin is associated with fewer bleeding complications, including intracranial hemorrhage, without a significant difference in ischemic events when I compare to the classic triple therapy, which is defined by warfarin plus aspirin plus clopidogrel. So where we are now, I think we came a long way. I think that now we can say that the default for this patient population is really using the NOAC plus a P2Y12 inhibitor, so dropping aspirin, stopping aspirin after the PC around the time of PCI. So in other words, 5 days, 3 days, basically in hospital period, we can use aspirin and drop aspirin. We also learned, I think very importantly, that the classic triple therapy with warfarin, aspirin, and clopidogrel should generally be avoided. If we need to use warfarin for some patients, such as mechanical valves patients, it's okay. But I think we learned clearly that we should stop aspirin for those patients because the classic triple therapy gives us only a lot of bleeding with warfarin without any additional benefit. We also trying to refine now for how long can we use aspirin, and I think we have some good data, not perfect, but some good data showing that if we have a patient a very high risk of ischemic events, stent thrombosis, maybe keeping aspirin for 30 days seems very reasonable because beyond 30 days, we really don't get too much from aspirin in terms of reduction in ischemic events, and we only gain bleeding. Finally, now we are getting to see consistency across guidelines because now guidelines are using all the same data, all the same high quality of data. And therefore, when we have that, we start having more agreement. After 12 months now, we realize that most patients can be on an anticoagulant alone without any antiplatelet for most cases. And of course, there are many other options that can be tested or implemented in practice in terms of antithrombotic therapies. However, if we really want to do them, we need to do the randomized trials to know if they work or if they don't work. Here, the recent 2020 non-STEMI guidelines, ESC guidelines, and in the session about AFib and PCI, I think that they now, again, based on the data we have, got it right, that the double therapy is going to be the standard of care, and we're going to stop aspirin around the time of PCI. At the same meeting, 2020 ESC guidelines, 2000 ESC meeting, the AFib guidelines were released. And also when you look at the session with ACS and AFib, also very similar recommendations now, where the default will be triple therapy only for the peri-procedure or in-hospital period, around 1 week. And after that, the default really being double therapy without aspirin. And of course, being able to customize if high risk for bleeding, we can keep aspirin for 30 days, or if high risk for ischemic events, we can keep aspirin for 30 days, or if high risk for bleeding, we can stop the antiplatelet at 6 months and continue from then on only with anticoagulant. And more recently, Dominick, who is in the call here, chairing the session or co-moderating the session, put together this really nice document on the North America perspective, also now summarizing the key recommendations with this nice figure, which again is aligned with the ESC non-STEMI guidelines, it's aligned with the ASC AFib guidelines, clearly showing the default triple therapy only for the peri-PCI period, double therapy afterwards. We can keep triple tap with aspirin, very high risk for ischemic event for 30 days, or we can stop all the antiplatelets if very high risk for bleeding at 6 months. And I think this really get us to the sweet spot that we are talking about. And I think that's really our goal, is a dynamic process trying to find the sweet spot, because these combinations might change over time in different time points. But if we find the sweet spot that gives us the greatest reduction in ischemic event, where we minimize bleeding risk, in other words, we can minimize bleeding risk, but by preserving efficacy, then we really found the sweet spot and we can give the best we can to our patients. So thank you very much for your attention.
Thank you. Thank you. It was very brilliant. We see that in those three lectures, how complex and difficult is the balance thrombotic risk versus bleeding risk in different situations, TAVR, AF. So now it's, I'm happy to open the discussion. Who wants to ask the first question to our lecturers? It was 3 wonderful lectures. Okay, Dr. Goto, please.
Well, I would like to start with, interesting and probably essential topic, that is the, balance between bleeding and thrombosis. Previously, the story is simple because natural cause is much with the high risk of thrombotic event. Now the standard of therapy become good and good every year. The natural cause of thrombosis become very low. Now the problem is the bleeding. Bleeding is iatrogenic. So that, I like the idea of net adverse clinical event raised by Dr. Cohen. I mean that, it's a kind of 2 different dimensions of the event. One is rather natural cause. The other is rather iatrogenic. So, it is very hard to make a balance because the, 2 of the dimensional events are really different. How could could we make a kind of one parameter to make a very good balance?
Can I answer that, Marie-Claude? Let me just show something. Can I share my screen? Is that possible? Here is something we've been talking about. Shinya, this is called a bivariate analysis. And what you do is you plot simultaneously the reduction in risk of bleeding and ischemia. So here, as you move to the left, you see a point estimate where you reduce the risk of bleeding by, say, 10%. And then going up and down is the risk of ischemia. And here you see it lies at 0, no increase in the risk of ischemic events. And you plot the confidence intervals surrounding that point estimate for both safety and efficacy. You then draw a box around it, and basically there's some fancy math where you compare these boxes to see if they differ from each other. But this is a mathematical way and also a graphic way of doing what you're saying, Shinya, that shows both safety and efficacy in the same plot. It allows you to analyze it quantitatively as well. But people often want to see efficacy and bleeding separated, but they also want to be able to see how they look together. So I just wanted to kind of throw that out there, Shinya.
Thank you, Mike. It's kind of a 2-dimensional analysis that is very helpful. I'm raising the issue that, the 2-dimensional of the event is really different in nature. One is natural cause, the other is so-called iatrogenic. So, emotionally, there is a different impact of the event. I agree that the 2-dimensional analysis would be very good, but probably multidimensional analysis, including other factor, other parameter like cost or value, estimation from the personal view will be included in the, future analysis. I like your, two-dimensional analysis. Thank you very much.
Dr. Cohen, do you want to comment?
Yes, I mean, I would just, I agree with, with this impression that I think the idea of keeping the events separate, but for analytic purposes, but combining them for interpretation is a very, very reasonable way to go. The graph that Mike showed is really identical to the work that we did a decade ago in the that I showed the graph from the Triton trial, where we explicitly looked at the different patients and the characteristics within the trial. And I do think that is, it certainly is a way for us to try to understand these trade-offs, both at the population level, but also more importantly at the individual level, where we are trying to make decisions, and to give us, again, something to, we've always been saying ever since all of these issues came to light, and we recognize the challenge with bleeding. I remember when, Laura Mori presented the DAP trial first at the AHA a number of years ago, and the conclusion was, well, we have to individualize therapy because there are trade-offs. And now we are really getting to the point where we can understand and quantify those risks and benefits, and make those trade-offs explicit, and help our patients and help our clinicians to make the right decisions based on each patient's combination of risk factors. So I think we're all striving towards the same place.
And that's where machine learning and AI comes in. We've applied those tools to do just that. If you're 80 years old and you have a creatinine of this, and et cetera, you can get a prediction of the absolute, not just relative, but absolute risk of ischemic events and absolute risk of bleeding events. Yep. The other thing is you can predict at the beginning of a study, but as people go on over time, they change. And if you've gone on for a year and you don't bleed, you've kind of declared yourself as being a potentially someone who's not going to be at high risk of bleeding. So we need iterative models of risk that take into account the patient's behavior over time.
Thank you. George, Dr. Dangas, it's let's say in TAVI we are missing a lot of data to at least for the patients that are not on AF to decide on the best antiplatelet treatment option and duration.
Well, indeed, we do miss. It's interesting that the TAVI field has gone so advanced, one can say, and widespread, and there has been little motivation from the device makers to explore the real patient outcomes. I think they're very super focused on their gradient world, one can say. You put a valve in, you get a gradient down, then they run out of there. And that's pretty much how it has gone. And I think we got to go a little bit beyond that. And we find interesting things. We were shocked by the advent of the case reports of leaflet thrombosis, which is essentially an imaging finding, an imaging enabler, one can say. This is not a new finding. It happens to the valves all the time. We just got a new imaging method. And also there lies a difficulty in studying, because it's an expensive study. It can be done only in high-tech centers. It requires dye. These three things limit that how easy this is. If we had a way to study this that would not require these three limitations, we would be very far along in this quest much earlier. But what we've learned is that it is important, it's unpleasant, it may have some durability, so you want to take care of it in some ways. On the other hand, how can you make it safe? We tried with intermediate dose rivaroxaban. That was attractive. Actually, quite frankly, it was criticized at the time. Why is it not full dose? And that there would be no efficacy with a low dose. Interestingly, we found out that you can avoid these clots even with low dose. That's a tremendous understanding. So, and now we can further analyze and say, you know what, why did we give combination therapy? Maybe monotherapy might be a good one. Why did we give it long term? Perhaps just 3 months might be good enough. So I think we're learning a lot of things. I think the next quest would be to try a shorter term a single therapy in a relatively low risk population, and that might be the key. In patients who really are threatened by the durability question are the younger ones that relatively younger ones who are expected to live long time, and also at the same token they're gonna at the same time be lower risk for bleeding. So in this context, I think we're gonna see this be advancing. And we hope the AF part to be settled by these two studies, one of them with well-adjustable dose, the TAVI, the envisaged TAVI-AF with a doxaban 30 or 60, and the other one, the apixaban 5 BID full dose. At the same time, there's a little bit of a mixed population there, so we see how the in the end of the study, how many actually will be those who have a requirement for anticoagulation and those who don't. I think I want to caution in that in this anticipation. It's really two sub-studies pasted together, not a homogeneous study. I think that will be very interesting, though, both.
Thank you. Yes, Dr. Kim?
Okay.
Yeah.
I have a question to Dr. Lopes. So,
yes.
As everybody knows, the most AFib ACS patient, we usually use the potent P2Y12 inhibitor. So, but the most AFib RCT usually use the clopidogrel as the P2Y12 inhibitor monotherapy. So, if that when you should use the potent P2Y12 inhibitor, can you change it into clopidogrel or some change of the doses of NOAC? What's your opinion?
So, Dr. King, great question. I'm not a big fan, and I don't think we have any data to change the dose of a NOAC because of the type of P2Y12 inhibitor that is used. I think that was recommended in a few of the guidelines documents or guidance documents in the past, but I don't think we have any data to change what we know based on an association of more drugs. So I will not go in that route. In terms of other more potent P2Y12 inhibitors, I think if we look at all the 4 major DOAC trials, we had about 10% of patients who used ticagrelor. And when we look at that subgroups, we found that in general, the treatment effects are preserved when we use ticagrelor. Obviously, in terms of absolute numbers, we have more bleeding with ticagrelor because it's a more potent P2Y12 inhibitor. But in general, the results were preserved. There was no signs of heterogeneity or different directions of the results because of a P2Y12 inhibitor, in this case, more potent, in this case, ticagrelor. So I'm pretty confident in using, comfortable using ticagrelor when I think that the risk of stent thrombosis is high, or when patients had a prior stent thrombosis, or when the risk of ischemic risk is very high. When I do that, we do without aspirin, and I think we have the data to support that. Prasugrel, on the other hand, we don't use in general because the numbers were very low in the trials, about 1.5%, and I don't think we have enough data with prasugrel, which we know is a very, very potent P2Y12 inhibitor. So I think that clopidogrel should be the default, but ticagrelor is completely acceptable for high-risk patients, high-risk for ischemic events patients.
Thank you.
Well, Dr. Lopes, I have a question. This is Dr. Kaul. That you have elegantly shown the futility of the use of aspirin in, your very well conducted Augustus trial. My point is that in the first 30 days, still, in high ischemic patients, we still continue to use aspirin, having shown many times that aspirin does not add anything. Do you have any data to, support this aspirin for the first 30 days?
Yeah, so that's a great question. And we actually have a very nice analysis that we published in Circulation a few months ago, where we tried to combine, going back to David's point, how can you hierarchically look at ischemic and bleeding events? So very difficult to do, but we tried to combine bad bleeding, severe bleeding events, and bad ischemic events, severe ischemic events. And trying to do an analysis where we look at different time windows of use of aspirin. And basically what we showed very interesting is that in the first 30 days, aspirin does increase bleeding in almost identical proportion that aspirin actually reduces ischemic events in a one-to-one match almost. So basically, if you keep aspirin, you're gonna bleed more in the first month, but you're gonna have less ischemic events. But after 30 days, clearly you have no impact in ischemic events with aspirin and only the same amount of increased bleeding. What this analysis showed is, okay, if we need to use aspirin, if the risk of bleeding is relatively low and you have a very high risk of ischemic events, because of the one-to-one ratio in the first 30 days, it makes sense to keep aspirin for those patients because you're gonna get more of the reduction in ischemic events than from bleeding. But after 30 days, absolutely not. Then there is no reason to really use aspirin at all because then we are only getting the bleeding part without the benefit. So that's, again, it's not perfect, but it's probably the best data we have out there is a randomized comparison. And what the key question that we don't have is who are those patients that you might keep aspirin for 30 days instead of 1 week? And this is something that Roxana and Mike and Chris and others and we are trying to put together a patient level meta-analysis to increase the power and try to identify, okay, now we know that 1 month maybe is for some patients, but let's try to find out who those patients might be and what the PCI characteristics might be that might lead us to keep aspirin for 30 days. So that's the work that is ongoing now.
Thank you.
I think it's time for us to move to the second half of the session on the disparities, racial disparities on antithrombotic strategies. It's very important topic. So please, you want to introduce the first speaker, Michael? Or you want me to do it?
Go ahead.
So the first speaker is Dr. Levine, antithrombotic therapy in East Asian with ACS PCI. Updated evidence from the East Asian paradox. Please.
Great, thank you. So it is a great honor to be invited to this wonderful meeting. I thank the organizers. I'll be talking about antithrombotic therapy in East Asians with ACS and PCI. I have no disclosures. I think first and foremost, we have to acknowledge Dr. Young-Hoon Jang, who first coined this term back in 2012. Well, in 2014, I was privileged to be part of an international group that systematically looked at this concept of the East Asian paradox in patients undergoing ACS or PCI. One of the things we and others described is that East Asians have a higher prevalence of the CYP2C19 loss of function alleles. It was approximately 30% in whites versus approximately 60% in East Asians. And this higher level of platelet reactivity or less inhibition with clopidogrel therapy was observed in East Asians. For example, in this study, as you can see, a much higher incidence of intermittent or poor metabolizers in Asians compared with Caucasians or African Americans. We also see differences with prasugrel and ticagrelor. With prasugrel, platelet inhibition with the prasugrel active metabolite is 30 to 47% higher in East Asian patients, and inhibition of platelet inhibition is comparable with 10 milligrams daily in white patients and only 5 milligrams daily in East Asian patients. When we look at ticagrelor, exposure of the same doses of ticagrelor is about 20 to 40% higher in East Asian patients than white patients. And platelet inhibition with the same doses of ticagrelor is about 40% higher in East Asian patients than white patients. For example, here is one study where we can see that inhibition of platelet aggregation is much higher in East Asian patients than Caucasian patients with clopidogrel. So what is the paradox? Well, the first part of the paradox is that although East Asian patients have a higher prevalence of high on-treatment platelet reactivity, in other words, less platelet inhibition during clopidogrel treatment than white patients, the incidence of adverse ischemic outcomes or stent thrombosis after PCI is actually similar or lower than that in white patients. Here is some evidence to support this. If we look at early registry data, these are the first generation stents in patients treated with clopidogrel. We can see the incidence of stent thrombosis is much lower in East Asian registries than it is in a Western registry. The second part of the paradox regards bleeding. East Asians are at greater risk of warfarin-associated intracranial hemorrhage than white individuals, despite a similar INR. And similarly, some studies also report a greater bleeding risk on the same doses of DAPT in East Asian patients. Well, what accounts for this East Asian paradox? It is probably multifactorial. It probably includes hemostatic and thrombotic differences, including differences in levels of hemostatic factors and differences in endothelial function and activation, as well as pharmacokinetic and pharmacodynamic considerations, including smaller body size and lower BMI of East Asians, differences in drug metabolism, and relatively lower renal clearance of East Asians. If we look at what we call the therapeutic window in Western populations, looking at low platelet reactivity and high platelet reactivity boundaries, when we look at East Asians, we now know we need to adjust these boundaries and, in fact, adjust what we consider to be the therapeutic window in East Asian populations. Now, has these early descriptions and findings stood the test of time? And the answer is yes. Over the last decade, there continues to be data supporting this concept of an East Asian paradox. And this is now extended to not only the P2Y12 inhibitors, but the DOACs as well, where we see significant differences in the response to antithrombotic agents between East Asians and Caucasians. If we look at the annual risk of intracranial hemorrhage during DOAC treatment in Asians versus non-Asians from the major randomized clinical trials, again, we can see at the same dose of DOAC, much higher incidence of intracranial hemorrhage in Asians compared to non-Asians. The most recent and very important data comes from the host-reduced Polytech ACS trial published just last year in Lancet. This was a trial of de-escalation, decreasing prasugrel to 5 milligrams versus standard dosing, which is 10 milligrams of prasugrel in 3,000 South Korean patients with ACS undergoing PCI. And as you can see at the top graph, the de-escalation therapy or strategy led to significantly lower incidence of the primary composite outcome. There was no difference in ischemic outcomes, and as we'd expect, much lower bleeding. There have been several updates to our initial statement, most recently in 2020. The key figure from that update is displayed here. And what we can see on the left is there continues to be clearly a different therapeutic window for inhibition of platelet P2Y12 receptors in East Asian patients. And if we look on the right side of the slide, we can also see similarly there is a clear different therapeutic window in East Asians with regard to DOACs and anti-10A activity. So our conclusions and take-home messages are as follows. East Asians have lower atherothrombotic risk, but higher bleeding risk than non-East Asians, particularly if dosing is not tailored. The East Asian paradox, first described a decade ago and in relation to clopidogrel therapy, continues to be expanded and validated, now including the more potent P2Y12 inhibitors and the DOACs. Data, trial results, dosing, and recommendations that are based upon the US and European populations, studies, and guideline recommendations should not necessarily be directly extrapolated to East Asian populations, and tailored or personalized therapy in East Asians, particularly dosing, continues to be advisable. Thank you.
Thank you. Thank you. It was very, very clear message, very transparent, very well given. Now it's Dr. Takeshi Kimura. That the talk is about less is more in antithrombotic therapy after PCI, clinically relevant not only in East Asian but also in Western population. Dr. Kimura, please.
Okay, thank you, Marie-Claude. Dr. Gibson, thank you very much. Okay, let me start with the history of antiplatelet therapy in PCI. The antiplatelet therapy in Japan has been much different from the global standard. We started with DAPT with ticlopidine 100 milligram BID, which was much lower dose compared with the global dose of ticlopidine 250 milligram BID. Then we moved to clopidogrel 75 milligram maintenance dose as a same as the global dose. So this is the historical comparison of the 30-day outcomes in PCI patients between Credo Kyoto Registry cohort 2 and cohort 3. In the cohort 2, we use the ticlopidine 100 milligram BID in most of the patients. And in the cohort 3, we use clopidogrel 75 milligram QD in the vast majority of patients. If we look at the 30-day outcome of major bleeding, it was significantly higher in the cohort 2 than in cohort 3 than in cohort 2. So even after very extensive adjustment, including the transradial approach, cohort 3 was associated with significantly higher risk for major bleeding. So the ticlopidine 100 milligram BID might be less potent than clopidogrel 75 milligram QD. Nevertheless, if we look at the myocardial infarction and ischemic stroke, the adjusted hazard ratio was 1.15. So the Japanese dose ticlopidine compared with global dose clopidogrel might be associated with lower risk for major bleeding without increased ischemic risk. So currently, we are using prasugrel 20 milligram loading dose and 3.75 milligram maintenance dose as compared with the 60 milligram loading and 10 milligram maintenance in the global dose. In the Triton TIMI-38, prasugrel demonstrates significant reduction of cardiovascular death, MI stroke. However, it was associated significant increase in non-CABG related TIMI major bleeding. Daiichi Sankyo made a great decision to conduct the Japanese pivotal study of prasugrel using the dose of 20 milligram loading and 3.75 milligram maintenance. The reduction of CV death and MI stroke was very comparable to that obtained in the Triton. And however, the TIMI measure breathing was very similar between clopidogrel and prasugrel. So the Japanese dose prasugrel compared with global dose prasugrel was associated with similar efficacy in reducing cardiovascular events without increased bleeding risk, although the PLUSFIT ACS trial was an underpowered study. Now, ticagrelor has never been used in Japan, almost never been used in Japan. So we have two East Asian studies comparing ticagrelor versus clopidogrel in ACS patients. One is PHILO trial conducted mainly in Japan. Dr. Goto Shinya is a PI of this trial. And we also have TICA Korea trial, which was conducted in Asan Medical Center in Korea. Dr. Park is a PI of this study. The true trial was very consistent, showed very consistent result. And if we prove these two trials, ticagrelor as compared with clopidogrel was associated with significantly higher risk for major bleeding. And also the ticagrelor as compared with clopidogrel was associated with significantly higher risk for cardiac death, MI, or stroke. So the less is more is in antithrombotic therapy after PCI was clearly demonstrated in East Asian population. So we conducted the STOP-TAP2 trial, 1 month DAPT followed by clopidogrel monotherapy compared with 12 months DAPT was non-inferior for cardiovascular events and superior for major bleeding. If we look at the meta-analysis, so these global readers, Smart Choice, STOP-TAP2, Twilight, and TICO. Smart Choice, STOP-TAP2, TICO was the East Asian trials. Short DAPT was consistently associated with lower risk for bleeding without increasing ischemic risk in East Asian population. And also, short DAPT was associated with lower risk for bleeding without increasing ischemic risk in Western population. Global readers has a complex protocol, but if we focus on ACS patients and look at the 1-year outcomes, ticagrelor monotherapy beyond 1 month was associated with significantly lower bleeding as compared with DAPT for 1 year. And also, it was not associated with increase of all-cause death, but rather it was has a trend toward a lower risk for all-cause death. And finally, recently reported the Science 2028 aspirin monotherapy after 1 month DAPT demonstrated substantial benefit as compared with the historical control of 12 months DAPT in global trial. So less is more might be relevant in Western population also. So in conclusion, less is more in antithrombotic therapy after PCI has been clearly demonstrated in East Asian population. Recent short DAPT studies have suggested that less is more might also be relevant in Western population. So finally, we are very excited to have started enrollment of the STOP-TAP3 trial exploring completely aspirin-free strategy. We are going to enroll ALC, HBR, or ACS patients without exclusion criteria. The unique aspect of this trial is we are going to get informed consent before angiography, even in ACS patients, and randomization will be performed after angiography, but before PCI, randomized to either no aspirin group versus 1 month DAPT group. All patients receive prasugrel 20 milligram loading dose. No aspirin group receive prasugrel monotherapy for 1 month, and the 1 month DAPT group receive DAPT with aspirin and prasugrel for 1 month. We do not set the control group of prolonged DAPT, but rather we will do primary analysis at 1 month, evaluating both bleeding endpoint and cardiovascular endpoint. Thank you very much.
Thank you. It was excellent. Mitch, do you want to introduce that Roxana Miran for the last lecture of today?
Great. Well, let's now turn to Dr. Roxana Miran, who's going to talk about potent P2Y12 inhibitors for East Asian patients, insights from the twilight in Western versus Asian population. Dr. Miran.
Thank you all. Thank you, Dr. Morice, Dr. Gibson, the entire organizing committee of the TCT Asia Pacific 2021. I'm here to talk about a little bit about Eastern Asian versus Western patients. Important on the disclosure side is the twilight study that I will be discussing was a investigator-initiated study sponsored by the Icahn School of Medicine, but through a grant, a significant grant from AstraZeneca. We heard from Dr. Levine about the work that he's done with the World Heart Federation on this important expert consensus regarding the paradox that has been seen in the East Asian population. This is pretty important when the therapeutic window is moved, and very importantly for the East Asian population to the right, with having more bleeding but yet less ischemic events at a therapeutic window for anticoagulation or antiplatelet regimens. And I think which one is optimal and what we do in the East Asian patient population is a very, very important one. For example, we heard from Sensei Kimura that the dosing for prasugrel is incredibly different in Japan than it is in the Western world. And of course, ticagrelor is not even being used there. So I think it's really important to understand this risk-benefit calculus for short duration of DAPT or even aspirin-free strategies, which could be very important and incredibly beneficial, I think, not only in the Western population, but most importantly in our East Asian PCI patient population. There are limited data, but let's see what we have from Twilight. As you know, this was a double-blind placebo-controlled trial with a 3-month open enrollment period of aspirin and ticagrelor in all those 9,006 patients who were enrolled. And at 3 months period, patients were visited in person, evaluated for adherence. And then if they were adherent and free of important ischemic events and severe bleeding events, BARC3C and more, then they were qualified to be randomized in this double-blind placebo-controlled trial where the experimental drug was actually aspirin. So ticagrelor plus aspirin, ticagrelor plus placebo was evaluated. Let me show you the global aspect of the Twilight patient population, 187 sites across 11 countries. 23% of our patient populations were Asian from China and India, thanks to the work by Professor Han Yaling and Professor Kaul for allowing this to happen. Here was the primary endpoint, and we did not use a NACE event. We used a composite of bleeding. This was a superiority endpoint for the entire trial, showing a major benefit in a ticagrelor monotherapy compared to dual antiplatelet therapy with aspirin. And importantly, the non-inferiority margin was met for the safety endpoint of death, MI, and stroke in this trial. a very important sub-analysis for the bleeding endpoint. I want you to pay attention to the region of enrollment showing the benefit in Western as well as the Eastern countries, especially East Asia. And you see that here in favor of ticagrelor plus placebo, as were importantly the key secondary ischemic endpoints. As you know, this was a across the line of unity, but look at the point estimate for ticagrelor plus placebo in the patients who were, of course, this again, we're underpowered for this evaluation, but the point estimate is on the right direction. In fact, perhaps, again, underlining what has been talked about by and Sensei Kimura. The STOP-DAPT-2 showed very, very similarly. Here, they went after a month to clopidogrel monotherapy in this NACE endpoint showing a superiority for that primary endpoint of death, MI, stroke with clopidogrel monotherapy in this patient population, mostly in Japan. And remember the wonderful work that they do with intravascular imaging at the time of PCI. I think we see a lot less ischemic events in this patient population due to the wonderful PCI work that's done in these cath labs. But very important, the non-inferiority of the ischemic events, reduction in bleeding. And then, of course, in Korea, the smart choice with 3 different stent platform, 3 months of dual antiplatelet therapy followed by clopidogrel monotherapy, showing non-inferiority in that major adverse cardiovascular events of death, MI, stroke in 3,000 patients, and a reduction in bleeding events, again, in favor of less is more in this patient population. Finally, I think one of the most important studies with acute coronary syndrome patients, including STEMI, in Twilight, we did not include STEMI, showing in this Asian population, 38 hospitals in South Korea, again, less is more, less bleeding, and in fact, even the ischemic complications are in the right direction with no difference at all. The p-value for ischemic complications was 0.09, really showing a very, very interesting reduction in both in bleeding for sure, in NACE, and the major adverse ischemic events being very, very similar. Less is more in this population. So I think we have now in this session have shown that the East Asian patients really display a very different risk profile. We have to be thinking differently. Higher risk of bleeding and their ischemic endpoints are lower. The monotherapy is a very, very interesting way of approaching such patients, but also the Western patient population, selected patients, short duration of DAPT followed by P2Y12 monotherapy. The big question is, what do we do after a year when all of this is said and done? Do we just keep P2Y12 indefinitely, or do we go back to aspirin? That's not been very well evaluated, but I think this novel approach has worked very, very nicely in the high-risk East Asian patient population undergoing PCI. Thank you so much for your attention.
Thank you. It was brilliant, really brilliant. Dominick Angiolillo, you had no opportunity to discuss your point of view. So now it's your time.
Yeah. Sure. A lot of great comments before, and I would like to break the ice here and ask Glenn a question. Glenn, you gave a very nice overview on the East Asian paradox, but I want to play a little bit the devil's advocate here. As it relates to 2 very important trials that Roxana alluded to, Smart Choice and the STOP-DAPT-2, where in most of these patients, when they stopped aspirin, patients stayed on clopidogrel. Now, you nicely alluded to the very, very high rates of loss of functional alleles in East Asians. And the patients I'm mostly concerned about are the poor metabolizers, right? Those with who are homozygotes for STAR2 or STAR3, which essentially have no antiplatelet effect with clopidogrel. So yet these were remarkably interesting trials with no excess in ischemic events. So yes, there is that East Asian paradox, but there was no excess in events. So your interpretation.
I think the findings are consistent with this whole concept that East Asians are not at as high ischemic and thrombotic risk as American and European populations. And we saw that in early registries, even with first generation stents, just a 1% incidence of stent thrombosis, 1/3 what we saw in Western populations. So I think it is best, as we've discussed, that we do not necessarily take our very American or Eurocentric concepts about what we need to do as far as platelet inhibition and necessarily extrapolate them to the East Asian populations, where clearly less inhibition is required. And in fact, when we do extrapolate what we expect we need to treat American and Europeans with, what we do is we wind up leading to increased bleeding, including increased intracranial hemorrhage. So I think the findings are very consistent with what we are all observing, and what some of our East Asian colleagues have pioneered in some of the studies that they've done, and some of the studies that we heard about.
Glenn, what do you think the role of diet is? I mean, they eat a lot more fish than we do. Fish has some antiplatelet effects. They obviously use a lot more imaging than we do. And there's a lot of alternative therapies they take. I mean, is it really a difference in vascular biology, or are there other things playing a role here?
Yeah, I think those are great point, Mike. Certainly in some of the studies, they've done more imaging, more intravascular ultrasound. And in some of those studies, they're probably a little bit more careful or compulsive about how they have deployed their stents than we do in our American trials. Certainly, diet could play a role, but I think, as you alluded to, there are multiple studies where there are clear biologic and vascular differences between East Asians and American and Europeans, and I think for us to ignore that just leads to suboptimal treatment of East Asians, and again, many of the people on this conference, as well as many others, I think take credit in pioneering these different regimens that we saw have worked out extremely well.
Ask Dr. Kimura a quick question regarding to the TAP3. Very interesting design. In the no aspirin arm, however, can you just correct me if I'm wrong, however, during the peri-PCI period, people are still getting aspirin, correct? It's just that discharge that's stopping aspirin.
No, most of the studies are evaluating the completely aspirin-free strategy, randomized patients after successful PCI, 1 or 2 days after PCI. But if we look at the timing of breathing complication after PCI, particularly in acute coronary syndrome patients, breathing events occur most frequently on the day of the procedure, and mostly within 3 days after the procedure. So prevent the breathing complication of ACS patients. I think it's very important to start completely aspirin-free strategy before PCI. And also, by including those type of patients, we could capture many events as compared with a sub-TAP2 TICO or something like that.
Thank you.
So the patients in STOP-TAP3 will not receive any aspirin even before
some patients actually have maintenance aspirin, but we stop aspirin just at the time of the procedure.
Thank you.
Dr. Park, you want to...
Roxana, I just wanted to ask you, given the limitations of the data which we had collected from South Asia, I know, and you both of us know that, do you think East Asians and South Asians had any difference?
Well, you know, the magnitude of the benefit was similar in reducing bleeding without increasing ischemic events. I don't know that there are important differences. We know the ischemic burden is a lot higher in the South Asian patient population. I was not at liberty to show the data from China as yet because it's embargoed and is being presented from, as you know, Twilight China was its own study, and it's being presented and published by Professor Han Yaling, and that's why I didn't show that. But there's no expectation that anything was very, very different. The ischemic burden is a lot higher in our patients in South Asia. Unfortunately, as you know, we had some issues in South Asia with the best possible ability of reporting of the events, although they did extremely well. I think they had a different risk profile of patients enrolled in the Twilight trial. And remember one other thing, I think it's really important. Twilight is very, very different than any of the other trials that have been presented. Number one, this was double-blind placebo-controlled trial. I think it's very different. And most importantly, was this period of enrollment versus randomization. We can only speak of those patients who were randomized, not those who were enrolled. And in fact, the higher risk patients were kind of taken out after 3 months, because if they bled or had an ischemic event, severe bleeding or a major ischemic event, then they weren't included in the randomization. So it's not everything to everyone, although in China, almost everyone who was enrolled was also randomized in this trial. So it's a very, very, very important difference, I think, to envision this for the Twilight study.
Thank you.
Okay, I have one just to comment is, that as a host of this meeting, I'm very grateful to everyone gave a very valuable lecture and discussion I cannot hear anywhere. My question is some practical question, and this session is participate the American doctor and the Asian and the India and my practical question in United States, do you consider race or ethnic based tailored antithrombotic approach, and how do you do in the David and the Roxana and the Mike, and you meet many Chinese and Korean in your clinic? How do you do?
We evaluate the risk of bleeding and ischemic events. It's really not a race evaluation, rather than their risk of, I think the westernized culture, unfortunately, has changed the ischemic risk of our Asian patient population with all the fast foods and everything else that's around here. And so we don't really consider that but I do consider them at risk of bleeding because of body size. Their body size is a lot smaller than our usual, high metabolic syndrome patient population. So I take all those things into account and evaluate them not by race, but by their other demographics. I don't know what others do, but that's what I do.
Well, I worked in San Francisco for quite a few years, and obviously many of my patients were of Asian descent. And you talk about biology, they had a very aggressive form of disease, lots of small vessels, a lot of metabolic disease. And in talking about what I was going to do in terms of drugs, I was also always struck by how many alternate therapies they were on as well that you had to think about. So, and their body mass index was much smaller. So it's very different having practice out there than on the East Coast.
And I'll speak for the Southeast in Florida. We don't have a lot of Asians in the Southeast. We actually have the opposite problem that we were discussing last week with Dr. Cohen. Our mean body mass index down here is like 45. So we have very, very big patients, and definitely not a lot of East Asian patients.
Yeah, I would. The Midwest perspective, where I was until very recently, is very much like Dominick's. Lots of X's on the XXXL size of shirts. In probably the same in Texas with Glenn, I suspect as well. For it, so I think, I would echo Roxana's comment that we do try to personalize the therapy quite a bit. We have bleeding risk scores, we have ischemic risk scores. We try to use that information, but race is not typically considered per se in the U.S. these days, and probably because, again, race in the United States, first of all, there's a lot of political issues around it, but secondly, it's not a very pure descriptor anymore. I mean, the U.S. is such a mixed population that we need to, really look at the biology rather than just the, ethnicity, I think.
So Dominick, let me just go back to you for one question, because I was very intrigued, and that's a fascinating aspect about the risk in the Asian patients. And also to Glenn, how can we reconcile the fact that when we look at stroke in every single trial, then Asians are at the highest risks of stroke despite similar CHA2DS2-VASc score? We have proven that many, many times. You look at the same CHA2DS2-VASc, non-Asian, Asian are at a much higher risk. And age impacting also much earlier the risk of stroke in Asian patients. So kind of the opposite that we described for the atherosclerosis risk. How can we reconcile all these? Are we missing anything here? I mean, in those associations?
Well, I think maybe one of the best people to address this question is Professor Goto, who, through my multiple visits in Japan, always explained about the difference in the prevalence in stroke risk. So a lot has to do with hypertension prevalence as well. Shinya, I think you're the most qualified person to answer this question.
Yeah, Renato, you raised a very important issue. I mean that, we discussed, we had a very tough time with the regulatory authority, whether Asian patient has a higher risk of bleeding, higher risk of stroke, lower risk of cardiovascular disease. Is that really true or not? If we, assume there is a, statistical difference between East Asian and global one, how can we get involved in the global trial? So, we need to say, there may be a difference, but the difference is within the fluctuation within the United States. You are absolutely right. Risk of ischemic stroke lifetime in East Asia is higher as compared to global one. Previously, intracranial bleeding, natural cause is higher in East Asia, but now that is already corrected. We have a strong perception having a high risk of intracranial bleeding, but that is only true with the use of VKA now, So we need to care about the thrombosis and the bleeding both, just like you do. We are people. I mean, the human being. So we want still stick to the global trial.
Shinya, does amyloid angiopathy play a role here? I mean, is there a difference in the disease of Asians versus Western cultures?
That is true. I'm probably due to the eating habit, so that not really depending on the genetics. If the Japanese population move to Hawaii or California, the bleeding risk is decreases, and cardiovascular risk is increases. It's a very old epidemiological study already established. So,
but if I move to Japan, would my bleeding risk go up?
Yes, but your cardiovascular risk will be decreased. Your life expectancy will prolong.
You have to change your diet too, Mike, though.
Yeah, you have to change the diet too.
Yeah.
I think one of the important factors, at least in our part of the world, India, hypertension, 43-44% incidence, uncontrolled hypertension, even in hypertensive patients, about 50%. Diabetes, uncontrolled diabetes, unrecognized diabetes in a large number of, population, maybe 12 to 15% of the population. So when you combine this and have other risk factors, dyslipidemias, lipoprotein little a being much higher, the risks of, vascular events certainly get multiplied. several times, keeping everything else almost the same. So that has been one of our, paradoxes here. Yeah.
Okay, Mitch, I think it's time to close this wonderful discussion, please.
Well, it's so great seeing so many of my friends. I've traveled to all your countries, to Japan, China, Korea, Brazil, even Texas. And I just wanted to say thank you for everyone in all the different time zones. But you know what I always learned when I was in Asia, I'd go and I present our Western data with some Asian data, and you would just look at me and shake your heads and say, we're different. And our risk of bleeding is higher, and you would always argue for 3/4 to half the dose. And you were into less is more way before less is more was cool, and really, you really have led the way in less is more. And I think we saw today that the world is coming to realization that the Asians had it right. So I want to thank you for inviting all of us. You put on a spectacular conference, and thanks for having all of us today.
Thank you.
Thank you. Thank you
very much.
Thank you. Wonderful.
Thank you.
Appreciate.
Thank you.
Great section.
Bye-bye.